we're going to talk about the actual mechanics of the ion flow and depolarization of the myocytes, right, or the muscles cells of the heart. So here they give you just some sample representation. I was drawing this when we did the cardiac and neuro chapter. They show you, right, the SA node here, and SA node is calcium dependent, and as here you have the heart rate of 75, so you definitely have more propagation of the impulse. When this occurs, when you have the threshold that's reached, right, you have the calcium sensitive channels for this membrane. When you have the parasympathetic stimulation, for example, right, the vagus nerve stimulation, and this is going to slow your heart rate down, right? You see the heart rate diminishes to 40. What happens is basically it becomes hyperpolarized. So it's driving the resting state more towards negative. Usually potassium channel and potassium voltage gated channels will do that, right? When you have sympathetic stimulation, that could be either your epinephrine fires or I gave you some atropine, right? Your heart rate increases because now the sympathetic stimulation is higher. So you see much rapid, right, increase. And another important factor here, right, you noticed, right, the threshold changes. And we're going to talk about some of this stuff. This is just a close-up view for this, right? So they show you threshold here. So let's say this is minus 40, let's say, millivolts, just using an arbitrary number, right? And they're depicting here the SA node, right? So now we just saw, right? So obviously if your heart rate is slow, there's less depolarization signals. If your heart rate is fast, you have faster depolarization signals. Bradycardia is anything less than 60. And tachycardia is anything above 100. Normal range is between 60 to 100. This is where we want to be for the most part, right? Now, let's say you have that sympathetic stimulation. It's, by the way, it's not under your voluntary control, right? This division of your autonomic nervous system, you cannot willfully control. The only one you could control is the somatic portion, right? Where you could contract the muscle or pick up a certain object, right? But the parasympathetic division and the sympathetic division, you do not control. It's controlled involuntarily. This system is under acetylcholine stimulation. This is under epinephrine or norepinephrine, right? The sympathetic division. They act on specific receptors, right? Which we talked about before, specifically for the heart. So I want to outline the ones that you need to know for the heart. So the parasympathetic system, which releases acetylcholine, is going to work on M2, which is muscarinic, right? M stands for muscarinic receptor, and this is on the myocyte. It's going to slow down the heart rate, right? They give you the enzymes, right? For your purposes, you need to remember cyclic AMP or adenylyl cyclase, right? These are the abbreviations. For your purposes, it's not as important. Which is important is parasympathetic system will slow down the heart rate. It's going to secrete neurotransmitter acetylcholine. It's going to work on M2 muscarinic receptors. It's going to slow down the heart rate. The other important one is for the sympathetic stimulation, and there's a couple of them that we need to know, right? So first of all, we need to know the beta 1, right? Where's beta 1? Beta 1 is here, tachycardia, right? We see the response. It's sympathetic. What is the neurotransmitter? Neurotransmitter is norepinephrine, or epinephrine is going to cause it. Which receptors for the heart? We said beta 1 on the cardiac pacemaker, right? It's going to increase cyclic AMP. It's going to increase adenylyl cyclase. It's via G protein coupled receptors. What about the parasympathetic side, right? We just talked about, right? Bradycardia is by parasympathetic stimulation. Vagus nerve will do it. All right, is going to cause muscarinic M2, acetylcholine. And the same thing we could say about cardiac contractility, the strength of the contraction with the sympathetic system. The other important ones that we talked about, right? We talked about vasoconstriction. Vasoconstriction on most blood vessels, usually it's the vasomotor tone, right? We talked about the vasomotor tone or the systemic vascular resistance, SVR or peripheral vascular resistance. I don't know if you recall, I was drawing a diagram like this, right? This is your aorta and this is your arterioles, and you have this constriction that's occurring here. This is under this, right? Vasoconstriction under the sympathetic control with norepinephrine, right, under alpha-1 receptor. And it's going to cause increase vasoconstriction, so it should drive your blood pressure up, right? We see this also. We see also something else. It's not going to be pertinent for the cardiac chapter, right? We talked about the beta 2. This is a bronchodilation. So there's a vasodilation here. It's going to dilate your bronchi. But for our purposes, the three that we need to be familiar with is, right, the epinephrine response on beta 1 and epinephrine response on alpha 1. Beta 1 is going to increase heart rate. Alpha 1 is going to vasoconstrict. Then you have parasympathetic acetylcholine, right? On M2 is going to cause bradycardia or slow your heart rate down, and is going to decrease cardiac contractility on M2 receptor. So those are the ones you want to be familiar with, right? This shows you essentially the innervation from your brainstem or your sympathetic nerves arising from the thoracic vertebra, right? So the vagus nerve, right? This is where you have your parasympathetic, right? You see it says medulla. Medulla is the brainstem. This is your parasympathetic stimulation, but your sympathetic is usually from your thoracic, right? Remember I showed you the diagrams. Directly comes in from the thoracic and then innervates your heart. The sympathetic is going to cause this beta 1 response on the heart, increased heart rate, increased chronotropy, increased dromotropy, increased contractility, right? So two different pathways, parasympathetic, sympathetic. Usually they're working together, but we could influence one or the other depending on medications, right? And depending on the patient's specific pathophysiology that's occurring, right? So this here shows you, right, the filling portions. We're going to get to it, right, about the stroke volume we kind of talked about. What I want to explain here is, right, how we actually obtain this stroke volume. The stroke volume, before I told you, right, it was about 70 ml. So how do we actually obtain it, right? If you look, the preload that's now coming in through your heart, right, during diastole, it's filling the heart. And when the heart is filled, it's called end diastolic volume. So this is all the preload that came in. So end diastolic volume. And usually end diastolic volume could be about 140 ml. Right? Now, the stroke volume that you're going to get, the stroke volume, is about 70 ml, we said. Right? And when the ventricles contract and they expel the stroke volume, in the remainder of the ventricles, you have end systolic volume. That's how much of blood will remain in your ventricles. They don't fully empty, right? And something else we can do something known as the ejection fraction. And the ejection fraction is basically what it does is it calculates, right, stroke volume over end diastolic volume. And then if you do 70 divided by 140, right, you get about, right, 1/2, or that's 50%. So your ejection fraction, right, is about 50% if it ejects 70 ml of blood, right? So we see that during filling, ventricles fill to about 140 ml. Then the ventricle starts to contract. They eject about 70 of it out, 50%, right? And then the remainder of blood in the ventricles is called end systolic volume because it's an end of systole. And then this process repeats. This is your basically cardiac cycle, right? So this is how they get stroke volume. How they can measure it, they can do an echocardiogram, or they can do invasively with this Swan-Ganz catheter. So this is basically how they measure these volumes. So end diastolic volume being the venous return or the preload, right? And the end systolic volume, the amount of volume that basically remains in your ventricles post-ejection after the systole, and all this that's ejected, this is your stroke volume, right? So any questions about this formula, right? How do you get the ejection fraction? Right, roughly speaking, 70 ml. This is 140 ml, about 50%. If your ejection fraction drops, let's say precipitously to like 20%, 10%, this is where you get placed on LVAD, left ventricular assist device, and you possibly become a candidate for a heart replacement. Right? So the other formula that I need to explain, right, after explaining all this is we need to know is the following, right? So before we had cardiac output was stroke volume times heart rate, but then there's something else, right? Blood pressure. Blood pressure is the determinant of cardiac output times systemic vascular resistance, right? So what is the systemic vascular resistance? So under the sympathetic and parasympathetic systems that we just explained, usually the vasomotor tone is controlled by a sympathetic division under epinephrine, norepinephrine, and predominantly it's done on this vasomotor tone on your small arteries and arterioles. So basically, if I draw this diagram once more, right, this is your heart, this is your aorta, and these are your small arterioles, right? They are under sympathetic stimulation, right? And these smooth muscles here, right? You have the alpha 1 receptors where, let's say this is alpha 1 receptor where norepinephrine or epinephrine will bind and it will cause vasoconstriction. So we're under this stimulation, right? And this is what we call SVR, systemic vascular resistance, or PVR. Predominantly, right? This resistance is under the arteries. However, right? There is also some on the veins. So this is also important to know, right? If I give you a vasoconstrictor, right? Am I going to affect the veins or not at all?
Yeah.
Not at all.
Not at all. So no, I will affect the veins, right? And what this will do, I can mobilize your preload stores, even though the distribution of vascular resistance is predominantly on the arterioles. Where is the predominance of your blood supply? In your arteries or your veins?
It's in the veins.
The veins, and it's about 60-65% of your blood supply. So if I vasoconstrict you, I can kind of push that preload to go forward. So your pressors do exert some effect on your veins, and they can mobilize that preload, right, to move that forward. Something to keep in mind. So what is this formula all about? So this formula is this, right? So first of all, we know what's cardiac output. Cardiac output is this, right? It's heart rate times stroke volume. Systemic vascular resistance is this portion here, this alpha 1 response on the small arteries. So now imagine you got a patient, let's use the same cardiogenic shock, right? The guy had a massive heart attack, right? He had a massive heart attack and his stroke volume is diminished. Even though his heart rate, let's say, is, let's say it's the same. Let's say his heart rate is 70 beats per minute. So let me draw it here, actually. His heart rate is still 70 beats per minute, but his stroke volume is down because his heart rate is not pumping. And let's say it's down to 20 ml, right? So his cardiac output here, we could see, right? 70 times 20 would be 1400. It's very low. His cardiac output is down. So now what can I do, right? Somebody told, right, they could, what can I do to bring his blood pressure up? What can I do to help this person?
Give him fluids.
Yeah, we give him fluids, and then after fluids, you want to give him some pressors. Why? Because I replenish, right? I basically push the fluid into this tank, into the venous side, and then I squeeze. I squeeze this with my pressors. I squeeze this, I increase my SVR. So I increase this with my pressors, and I give you IV fluids, right, with the venous side, which eventually goes into your left ventricle, and more fluid comes here. So hopefully I can bump up your blood pressure, right? So this formula basically tells me, right, how to increase the blood pressure. I can do it either increasing my cardiac output, or I can increase my systemic vascular resistance. How do you know which side to attack? You go based on what you got. So let's say you got a person who has bradycardia, right? Bradycardia. Heart rate is 40. Do I want to dump him? Do I want to give him fluids right away?
You want to give him atropine.
Yeah, so that's very good that you guys keep in mind, right? So remember, you want to fix the problem at hand, right? Even though right, if you give IV fluids, you could increase the SVR with pressors. First, focus on the problem at hand. So if I have somebody in bradycardia, heart rate is 40, right? I want to address this first. This is my problem right now. I want to maybe give him atropine. Maybe I want to do pacing. If that still didn't fix it, then I start looking at this aspect here. On the other hand, let's say you got a guy, heart rate 98, right? Is the problem with the heart rate 98? Probably not, right? It's not so slow that the heart is not working. Maybe now I want to attack this side of the equation, right? I want to bring up his SVR to get his blood pressure up. So always look at your patient, identify the problem at hand, and then address the most inherent cause, or I would say the primary cause first. Correct the primary cause. If you corrected the primary cause, you still do not have the effect. For example, I gave atropine, heart rate is now 69, 68, right? But he still has low blood pressure, right? So then I may go to this as a second device, right? As a second treatment option. But I never, right, with a heart rate of 40, start to give him 1 liter of fluids, right, to correct it. Why? Because his heart rate, he's already in cardiogenic shock, right? This 1 liter of fluid there's nothing that this 1 liter is going to do to increase my heart rate. Does that make sense?
Yep.
Yeah. So make sure, this is a very important lesson, because when we start doing scenarios, right, I give you a patient I tell you, okay, you got a heart rate 38, right? Blood pressure is 60/40. And the automatic response, what do you guys think it is? I'm going to give him 1 liter IV fluid, right? That's automatic response, right? And that's not the treatment. The reason why that's not the treatment, this 1 liter of fluid will not increase your heart rate. Right.
Nick.
Yeah.
Can you dilute atropine into the 1 liter and do it at the same time?
No, I would not do it. This will dilute it too much, because that medication needs to be given as a bolus, and the goal of that medication is to block the parasympathetic system to basically get the sympathetic system to fire. A lot of times you may have patients who don't just have benign Brady dysrhythmias, they may have heart blocks where that atropine may do nothing. Why? Because the AV node is not functional. So that could be basically, that drug can be used as your diagnostic tool, right? To see, right, maybe it's not working. So then you may need to go to transcutaneous pacing. But first, if you have a low heart rate in a setting of cardiogenic shock, address that first before you dump 1 liter of fluids in them, to further compromise them. So always address the inherent problem first. Okay?
Gotcha. Thanks.
Yeah, don't dilute that. This here just shows you distribution of the blood flow, right? Some of the terms that I kind of already used, but so you guys are familiar with. The preload is all the blood that's coming into your ventricles. It's coming in on both sides, not just the right side. It's coming in right side, it's coming in left side. That's your preload. Another term for preload is end diastolic volume. Afterload is basically all the forces that the ventricles have to overcome to push the blood out. So you have the afterload on the aorta. You also have the afterload on your right ventricle. So there's also an afterload here, right? So on the arterial side, obviously, it's going to be more, because your blood pressure, let's say if you have normal blood pressure, 120/80, right? You have to overcome 120 to propel blood out. If your blood pressure is 200/100, you have to overcome 200. On the pulmonary side, your systolic over diastolic is about 25/15. You only need to overcome 25. That's why it's smaller in size. Unless you have COPD, then those numbers change. Right? So the two terms, preload is all the blood's coming into your ventricles. Afterload is the resistance that your ventricles must overcome in order to push the blood forward. Right? The tank, right, is the veins. They are your capacitance. About 60% of your blood is stored in your veins. This is where your preload comes in, right, into your heart. Right? This just shows you ventricular filling, right? And if you know this Frank Starling's law, right? Frank Starling's law says the more you fill, right, the bigger the stretch, the bigger the contraction would be, up to a certain point, right? Obviously, you're not gonna be able to do that on a very weak heart. It's like if you had old underwear and the rubber is already gone, right? It's not going to be as stretchable. So if you have a myocardial infarction or you have heart that's hypertrophied, that's lost its function, you're not going to be able to get much out of it. But Frank Stallings law, what this is basically says, the more you fill, the bigger the contraction that you will get. And then the pump, right, your heart will basically contract in order to get that out, right? Inotropy is another name for contraction, right? That's why certain drugs you hear, they will call them inotropes, like the butamine, right? They're inotropic drugs because they increase contractility of your heart. So Afterload, we talked about all the forces that you have to overcome, and then the stroke volume, right? So stroke volume, right? And if you guys, let me just go back on this formula. Cardiac output is heart rate times stroke volume. So stroke volume is dependent on preload, right? It's dependent on afterload and contractility. So that makes sense, right? So how much of blood, we said normally is about 70 ml. So how much of that 70 ml will come out is how much came in from the right heart, right? The preload. The amount of afterload, how much resistance. So how much of this I gotta overcome. How much of this vasoconstriction I gotta overcome for the aortic valve to open in order to pump the blood out. This is your afterload, right? And then the contractility, the inotropy, how well your heart is working, right? So if let's say you have a massive heart attack, right? Maybe contractility is down, right? At the same time, your afterload may be up because you have vasoconstriction to compensate, right, for the low blood pressure, right? So that's why all these factors are important to keep in mind. So stroke volume is determined by preload, how much is coming in, afterload, all the resistance that the ventricles must overcome in order to eject blood out, and the contractility of the myocardium in order to push the blood forward. Right? So, and this is basically everything I just talked about, and they kind of give you the overview factors, right? The formula being heart rate, right, times stroke volume. It gives you the cardiac output, and they give you all the determinants. So what controls heart rate, right? What controls heart rate is your autonomic nervous system. Is nothing under your voluntary control, right? So, and then they give you some other parameters, but that's the main one that I want to keep in mind. The autonomic nervous system, specifically beta 1 response of norepi. And then your stroke volume, the predominant ones that you want to be familiar, even though they give you like these offshoots, is the preload, right? The afterload and the contractility. So these are what determines your stroke volume. Together, this and this is going to make up your cardiac output, right? Any questions about that? So both of these formulas are clear, right? Any questions about these two? So if you get a problem on your exam, how to calculate them, you know how to do it, right? Yes? No?
Yes, no problem.
Okay. Okay. Right. So, all right. So this just to show you, right, why I explained in here, right? Why is this under small arterial control? Why it's not the venous control is because if you look at the actual makeup of your arteries and veins, right? Look at the artery. You see how much muscle there is? This is called tunica. Tunica is like a coat, like a jacket, right? So it's layers, right? So tunica intima is the intimal layer, makes contact with blood. Then you have the media, and you have the externa or the adventitia outside of it. But look how much of the muscle there's here as opposed to the vein, right? The vein has much less of the muscle. It doesn't need it, right? Because the way it's propelling blood is via valves, which are closing and opening with muscle contraction. But this is under, right, sympathetic stimulation. So we need that musculature. They give you the lumens, right? So that's why I call them the tanks or the capacitance. And this is your distribution on the artery. And you see, right, the muscle layer is way bigger as opposed to the vein. These are also way more compressible. When you go in the ER and you will see them doing a central line, they're going to use ultrasound probe, and they're going to use a needle to basically like trying to find the subclavian, right, vein to put the central line, and you will see how they will collapse. Like as they're inserting it, you'll see how this lumen will collapse because veins are compressible, arteries not so much. Why? Because they're under high pressure, right? So this is just a more in-depth picture. By the way, these right portions, the endothelium, they're coated with specific factors, right? When they notice there's a breach in the lumen, they're going to secrete certain chemicals, right, like serotonin, ADP, in order to call on the platelets to come and aggregate. So the moment the integrity of this endothelium is broken with the blood, it's going to sense, oh, you know, this portion of the endothelium is broken. Let me plug up that hole, right? And it's all great and good if it's in the artery, let's say in your radial artery and you're bleeding in trauma, but that's not so good if it's in your coronary artery. We're going to talk about that momentarily, right? So this is basically shows you the veins, right? How they bring the blood into the heart. This shows you the venomotor tone of the arterioles. And the capillaries is where the actual exchange of your nutrients and oxygen and CO2 occurs, right? So here, the capillary, and it has the biggest surface area of all these, capillaries. This is the thoroughfare, right? The capillaries are here. Here you see the cells, right? And through these capillaries, we have essentially O2 is going to come out, CO2 is going to be picked up, and also the nutrients and the waste products, right? They'll be picked up from the cells. This could be any cells, myocytes, kidney cells, right? Anything like that. You know, it's the blood coming in, right? And then when we talk about the smooth muscles, right? Here, right? These are the ones that are going to be constricting in the setting of shock, in the setting when you give epinephrine to vasoconstrict. So this is what is going to constrict, right? And you notice, right, if I'm constricting, there's less blood flow where? To your tissues. So if there's less blood flow to your tissues, do you think you get adequate nutrient supply or oxygen and uptake of waste products? No, right? So in the setting of profound vasoconstriction, right? If you have very severe vasoconstriction, you could see how your cells and your tissues are not getting nutrients, are not getting adequate supply, right? Yeah, you're maintaining your blood pressure, but the blood pressure, but number in itself does not tell you of the perfusion status of your cells. So significant profound vasoconstriction is going to cause diminished blood supply and nutrient supply to your tissues. Right? Make sense? By the way, let's see any of you who paid attention. Right? Let's say I have severe vasoconstriction. Severe vasoconstriction. What type of glycolysis do you think these cells are going to run?
It isn't going to be acidic.
Anaerobic.
Anaerobic, very good. So, right, this is why you want to keep in mind, right? Why does the patient develop metabolic acidosis? Why? Because in the setting of, let's say, septic shock, cardiogenic shock, any type of shock, right? You have profound vasoconstriction, your body's trying to survive. It's going to vasoconstrict, right, in order to preserve the blood pressure. These cells are not getting, right, oxygen, they're not getting nutrients, the waste products are not being removed. So then the glycolysis pathway, right, we said in glycolysis, we go to 2-pyruvate. And then if in the presence of oxygen, then it can go into the mitochondria and do all that stuff. But in this setting, this is going to go into lactate. And that's where you get your lactic acid, right? Septic patients, we measure their lactate, lactic acidosis. So this is very, very important to keep in mind, right? On the venous side, right, you see all these valves, right? And the blood is taken back to the system when you have the contraction, right? And the blood basically moves up. These valves do not allow backflow. So contraction of the muscles, right, allows the flow of blood back into your right atria, right, and then going down. Sometimes you may, when you're starting IV access, if you put your catheter like right where the valve is, you may not get flow. So just keep in mind that may occur, right? This we kind of already talked about, compositions of blood. right? Where you see the predominant amount of blood is in your venous system. It's not, I repeat, it's not in your, right, in your arterial system. Only 13% of it in the arterial system, but this is the system that's under vasomotor tone, right? This system, if I squeeze this system, I get bigger preload. So if I give you a pressor and I have some a vasomotor tone on the sympathetic side on the venous system, I basically augment your preload. So more blood is coming into your right ventricle, right? So this shows you the sympathetic stimulation, right? Norepinephrine secreted, alpha-1 receptor, right? And what you see, right? Sympathetic nerves, you have smooth muscle contraction. Does it occur on the arteries? Yes, but you could also have some on the veins. Not profound, but yes, you can have some on the veins. What it's going to do is not going to vasoconstrict your veins too much. It's going to augment your preload. So this is what basically shows you here, right? You could increase your venous return, which is the preload. It's going to come into your heart, right? And this can essentially increase your cardiac output, increase the amount of blood coming out if you increase your preload. If you apply arterial pressure, you're going to increase your blood pressure. How? By peripheral resistance. This is your systemic vascular resistance. Norepinephrine is acting here, right, in order to cause it. So this is what we see. When we do a renal chapter, we'll talk about the response of your renin, essentially aldosterone system. So that's one also. This is very important here, but I don't want to spend time to talk about this. But this is very important in blood pressure regulation. So this just shows you the viscosity, right, of different fluids, and blood is relatively viscous. It's not as viscous as water. That's why, and also when we give you IV fluids, it's not as good as blood, right? So those who have heavy losses, they will need blood transfusions, but it's still viscous, right? So this here basically shows you the vessel lumen diameter, right? And the basically distribution, how it goes, all right? The flow through them, I should say. So you have the aorta and all the arterioles. This is basically your distribution. The capillaries are the cross section they show you, right? There's a big cross section. Why? Because all the exchanges occurring here, right? So all the exchanges at the capillary level. The arteries are basically distribute, and the veins is the capacitance portion. Here they show you average blood pressure of different compartments. So we know that blood pressure, let's say in your aorta, 120, right, systolic, over 80 diastolic. And as you make your way down, right, to the arterioles, to the capillaries, to the veins, the pressure decreases all the way to your right atrium, where the pressures may be like 2 millimeters of mercury. Sometimes they'll say 2 to 4 millimeters of mercury, right? So veins are low pressure, arteries are high pressure, they're under vasomotor tone here. And the velocity of blood, right, how fast it moves, it's much more turbulent in your aorta as opposed to your veins. Because of the lumen is larger, there's also less vasomotor tone on this side of it. Also, muscular layers are found in your right aorta. So that's why there's much more turbulence found here. Now, there's the final formula that you guys need to be familiar with, right? They show you map here, and the way you calculate this is 1/3 of your pulse pressure plus your diastolic blood pressure. So, anyone heard of the mean arterial pressure? What is that?
It's the systolic divided by diastolic. It's like 2 times systolic. I forget.
Well, tell me in plain, like, let's say, I don't need the formula, right? Tell me in plain English, what is mean arterial pressure?
It's like
Is
a
the
measure.
average-
Go ahead, Sad.
It's like a measure of where you're at. Like I know if you're under like 65, you're in shock or you're hypotensive or whatever.
Yeah, we're gonna calculate it in a moment, but what is it like? You're correct. We want the mean to be 65 millimeters of mercury. We want to be above it, right? If you're below it, you are in severe shock, so we want to augment it. You're correct. But what is mean arterial pressure? What is
It's the pressure in a single cardiac cycle.
It's so truly speaking, it's means average. So it's the average pressure in your arteries, right? It's the average pressure in your arteries. And you notice, right? They show you here like systolic 120, right? And the diastolic, let's just say they put it 90 here, right? Let's say 90. And they show, right, your mean arterial pressure is somewhere here, right? So what it measures is basically it measures the mean or the average pressure. Usually the most accurate way to do this is not with this formula. The most accurate to do this is you put a catheter in someone's artery and then you measure it. This calculation, you could do it, but really it's not really that accurate. The most accurate is basically with a central line, arterial line. I take a catheter, I place it not in your vein, I place it in your artery. I place a catheter in your artery and then I could measure your arterial pressure. In the hospital, those patients who are very sick, who are on pressors, that's how we determine how much pressors to give them. Now, how are you going to calculate it? So the way you calculate it, right? So let's say, let me use this, 120 over 80, right? So 120 is the systolic, 80 is the diastolic, right? So pulse pressure means systolic minus diastolic. That's your pulse pressure, right? So the way we're going to write this formula, and you guys can use your calculators. So MAP equals 1/3 times 120 minus 80 plus diastolic pressure is this, plus 80. So now, right, what is 1/3 times 40? You guys know, you can use your calculator. What is this, roughly?
13 and a third.
Yeah, 13.3 or 13, and then 13 plus 80 is about 93. So your mean arterial pressure is 93 for someone who has blood pressure 120 over 80. Usually what we want to be concerned about is when the mean arterial pressure is below this number, we want to increase it depending on what the person needs. Maybe we need to give him atropine, maybe we need to pace him, maybe we need to give him IV fluids, maybe we need to do pressors, right? So the moment this drops below 65 is when we need to come and address it. Something that you want to be cognizant about is the systolic number, right? Measures the contraction of your ventricles when they're squeezing. But the diastolic number, right? This number is actually measuring your systemic vascular resistance. So when this valve, the aortic valve, shuts, this is the pressure that's in your arteries, right? When there's no systole, it's basically diastole, right? And if this number is going down, right, what do you think is happening? So let's say this guy was 120 over 80. He got a heart attack in a little bit. His blood pressure is 98 over 84. Then it's 92 over 86. And then we see this number is 90 over 86, let's say. So what do you think is happening in the initial phases?
The heart's failing as a pump.
Yeah, the heart is failing, and you see vasoconstriction, right? The sympathetic system is vasoconstricting, so the diastolic is increasing. But then, right, when he stops to compensate, right, you may see this 80 over 40, right? This number is dropping precipitously because vasomotor tone is dropping. Your systemic vascular resistance is declining, right? And your sympathetic system can no longer compensate. We say he's in decompensated shock, right? So he went from compensated, right, all the way to decompensated shock. And the moment your MAP is less than 65, right, you definitely want to intervene depending on what the person needs, right? Any questions about this formula and how to calculate it? So it's basically mean arterial pressure is 1/3 times pulse pressure, which is systolic minus diastolic, right? And then plus the diastolic pressure. I can tell you, your state exam, your REMAC exam will have questions like this that will ask you to calculate. On a REMAC exam, they'll give you a calculator. But 100% you'll get questions like that.
Can you repeat that last part over again about the diastolic blood pressure? What it means when it gradually increases? I think I missed that.
Yeah. So in the initial phases of shock, right? What happens? You have dump of norepinephrine, epinephrine, because the body is now in shock, so it fires your fight or flight system, right? So sympathetic system is fired, and you have, let's say, norepinephrine or epinephrine releasing. It's going to come on the alpha receptors, alpha 1, right? On your peripheral circulation, which is here. And it's going to bind, and it's going to cause profound vasoconstriction. So in the initial phases of the shock, when you have norepinephrine, epinephrine dump, you're going to see this number, the diastolic number, may slightly increase. Why is it increasing? Because you have profound vasoconstriction on the arterial side, right? But after a while, if the compensation is lost, right, the person may decompensate, and this number, right, the diastolic number will drop slowly to the point where they can no longer compensate. That's why you see in decompensated shock, you'll see like blood pressures like this, right? 80/40, maybe 70/38, right? This number is dropping. It's no longer maintaining the vasomotor tone. Does that answer your question?
Yeah, I get it. Thank you.
Yeah. So make sure you know how to work this formula, or I should say this formula. Right? So pulse pressure, all this means is systolic blood pressure minus diastolic blood pressure. This. Right? This here they show you at the capillary level, right? Then you have something known as the colloid osmotic pressure, right? And this is usually with the capillary level with the embedded proteins like albumin, which is made in the liver, right? There's not any formulas associated with it, but this is what maintains the level of if you basically get edema or don't get edema, as long as you have adequate amount of protein, albumin in the interstitial space, right? And in both compartments, you should not have those problems occurring. Right. So this here shows you, right, blood distribution at rest, light exercise, heavy exercise. Obviously, right, you at rest, we talked about cardiac output being 5 liters. You notice your muscles do not really need too much blood when you're resting. But what happens when you start to exercise? Light exercise, all of a sudden the muscles need more blood, right? And what you can do, you could kind of correlate, right? In this, what you could say, early compensation. This could be your early compensation for shock, right? So early compensation for shock, you're probably not going to get all the blood flow to your muscles, right? But what's going to happen is you're going to start to get that vasoconstriction going, right? So the blood can start to go to your vital organs like your lungs, your heart, your brain, right? And this will go on until, right, you have those stores. But after a while, right, if your body can no longer compensate, you're going to go into decompensated shock. But this diagram just basically shows you when you start to exercise, your cardiac output increases because predominantly it's going to your muscle. Right? This is what I was trying to explain to you earlier, right? Your arterial side is high pressure system, right? 120/80 is your normal blood pressure. So you could see, right, systolic about 130 here. 80 is or here they give you maybe even less, maybe 70 is the diastolic. And then your pulmonary side, your pulmonary circulation, right? Look, maybe this is 25, right? And this is your diastolic phase, maybe 15. So your pulmonary side, right? Specifically in your pulmonary arterioles, right, is way, way less as opposed to your arterial side. And this makes sense. Unless you have pulmonary hypertension, then this number slightly changes. It's not going to be 120/80 per se, but this will definitely going to increase, right? We talked about, right, the mean arterial pressure. This is basically the average pressure, right? So this is being your systolic, right? This is the diastolic. Everything under the curve, right, would be the mean arterial pressure. The pulse pressure is the difference between systolic and the diastolic, right? So 120 minus 80 would be 40. So 40 is your pulse pressure. Sometimes you'll hear the term narrowing pulse pressure, right? What is narrowing pulse pressure?
It's when the heart isn't pumping effectively and the vasomotor tone increases.
Yeah.
Like you described before.
Yeah, so exactly. So let's say let's say, instead of being 120 over 80, right, where you have the 40 difference, let's say it's 120 over 100. So now you have 20. So this is narrowing pulse pressure. Sometimes you'll hear the terms widening pulse pressure, right? So instead of 120 over 80, let's say 120 over 60. So your pulse pressure is 60. So that's the widening pulse pressure. How you may see this, right? Like, for example, in a condition where you have Cushing's reflex, right? You have traumatic brain injury, your systolic is rising, right? And your diastolic is still remaining the same, right? You may have widening pulse pressure. In the early stages of shock, you may have narrowing pulse pressure. So that's why it's important. Why do we tell you, right, when you're getting your vital signs, don't just get the systolic by pulp, get your diastolic. Because if you know your diastolic is a measure of your systemic vascular resistance, right, it's important to keep that number as well. So you know if your person is compensating, decompensating, right? So what is my vasomotor tone doing, right? So narrowing pulse pressure, widening pulse pressure. If your pulse pressure is widening, maybe the guy or your patient is going into decompensated status of shock, right? In the narrowing pulse pressure, maybe they're still compensating, right? In that regard. Like I'll give you an example, right, of your Beck's triad earlier, right? That's where you have the heart and the pericardial sac is filling up with blood. And now the person is showing you signs and symptoms, right? So they could have jugular venous distension, right? They could have muffled heart sound, and they have narrowing pulse pressure, right? Why do they have narrow pulse pressure? Is because now, right, the ventricles do not fill, right? Because they don't have space to fill, so less of it is coming out, and you see this blood pressure of 90 over 84, right? And that's narrowing. So those are key things to keep in mind. It will help you with diagnostic interpretation. Okay, any questions about how to calculate your MAP and the pulse pressure distinctions? Definitely going to have questions about that on your exams, for sure. Right, so this is, I went through it, but this is just they show you, right? So how does stroke volume calculated? This is if you take your end diastolic volume, right? How much came into the ventricles, right? Versus when you contracted end systolic volume, how much remained after systole, right? So you subtract them, right? So let's say 120 came in, right? And then only 50 remained after the contraction, 120 minus 50, 70 went out. Then we calculate our ejection fraction, right? It's stroke volume over end diastolic volume. So here they give you an example of 70 over 120. They give you example 70 over 140, right? And here they give you 55%, right? So anything exceeds 50%, 55% is a healthy person. But anything like below that number, 30, 20, right? They have low ejection fraction. When you're going to do your critical care rotations, you will definitely hear about that. Anything like between 10 and 20, they're going to get LVAD, left ventricular assist device, or they're going to be placed on heart transplant list, right? This calculation will also come up on your tests. So know how to calculate ejection fraction and how this comes about, right? Normally they say it's usually we measure the left ventricular. Why? Because this is the systemic. We want to know how much the person is getting through the aorta to his vital organs, right? This is basically shows you roughly pressures in your pulmonary side, right, versus your arterial side. The pulmonary side, as I said, maybe 25 over 15 or 25 over 8. Just aorta, right, they give you 120 over 80, 130 over 80. So the aortic side is high pressure side. Pulmonary side is the low pressure side. These here, they show you the waves. If the person is connected to a venous monitor, where we could put a venous catheter in his vein and monitor his venous pressure, right? They give you venous pressure is about 8. We could see these A wave, C wave formation as a rolling waveform on the monitor. So that's where they get these names from: A wave, C wave, and D wave.